Assalamualaikum and hello everyone, welcome to this channel. In this video we are going to talk about approach to dyspnea. It is one of the commonest complaints and a lot of disease can cause this symptom. So let's try to organize and narrow down our focus group first. We can divide the causes into dyspnea in traumatic and non-traumatic setting. During primary survey in a trauma case, we screen for life-threatening causes such as listed here when assessing patient airway, breathing, and circulation. The first group are common and relatively easier to be appreciated with clinical examination, while the second group may require added investigative equipment. In a non-traumatic case, it depends on the age group, either neonate, children, or adult. We can divide the causes of breathing difficulties for all age group into respiratory and non-respiratory causes. For respiratory, it can further be subclassified into airway, pleural, and diaphragmatic causes according to the anatomy. Here are the examples of causes for each subgroup. Some may manifest as early as after birth, while others may manifest after several days. For children, similarly, we have respiratory and non-respiratory disease. Common diseases in children are usually involving the airways, less commonly due to other respiratory components such as the pleura or the diaphragm. In this video specifically, we are going to talk about dyspnea in adults, and it is more helpful, at least to me, to divide the group into acute and chronic disease first. And of course, we also have respiratory and non-respiratory causes. Generally, the symptoms in chronic illness are more insidious. Patient may present with a complaint of gradually worsening symptoms over weeks, months, or even years because they are worried or when the symptom starts to limit their normal day-to-day activity. However, at any time during the course of a chronic illness, they also can present with an acute condition. In fact, they are more predisposed to this acute condition due to their underlying illness. This is called quote-unquote acute on chronic disease. Those acute on chronic conditions, for examples, are pneumonia, secondary pneumothorax, atelectasis, pleural effusion, pulmonary edema, and exacerbation, for example, asthma and COPD, which can be triggered by lots of things. In this case, they may present with sudden or rapidly deteriorating symptoms, so it is important to do a complete clinical assessment. One of the clues is when the history do not correlate with the findings on physical examination, because some physical signs such as digital clubbing or cachexia cannot simply occur overnight or just a few days. Alright, there are a lot of differentials for dyspnea in adult alone. The best recommended approach to this, according to Professor Morta, is by identifying the onset and progression of the dyspnea. Dyspnea can be very sudden and patient may deteriorate quickly over seconds to minutes. These are seen in these cases. But of course, this is just a guide for you. It actually depends on how severe the condition is. For example, sudden dyspnea is seen in atelectasis when it involves major lobe, or pulmonary embolism when it involves major vessels. In the second group are those which dyspnea happen rapidly within hours, such as pulmonary edema, acute exacerbation of asthma or COPD, diabetic ketoacidosis, and pneumonia. Dyspnea in pneumonia can occur as rapid as 24 to 48 hours, so let's take that as a rough estimate regarding how rapid it is in terms of hours. Gradually worsening dyspnea can be in terms of few days or weeks, or up to months or even years. Dyspnea in atypical pneumonia, for example, are usually milder and slower in terms of progression of the symptom. Other examples are lung abscess and pulmonary effusion. Gradually worsening dyspnea over months or years, for example, are chronic anemia, tuberculosis, bronchiectasis, lung cancer, COPD, and interstitial lung disease. So that is roughly the introduction to dyspnea. In this video particularly, we are going to talk about some of the causes in the first and second group, along with atypical pneumonia. Other differentials such as acute coronary syndrome, pneumothorax, and pulmonary embolism are already discussed in the previous video. Before we begin, these are my references for the following content. Let us begin with atelectasis. It is the incomplete expansion of the lung or collapse of the previously inflated lung. The first part of the definition specifically pointing to neonatal atelectasis. There are three types: resorptive, compressive, and contracting atelectasis. The first one is due to bronchial obstruction, so sometimes this is also called obstructive atelectasis. Obstruction can be due to secretion such as seen in cystic fibrosis, COPD, bronchiectasis, or asthma, or due to mass such as bronchial carcinoma, peribronchial lymphadenopathy, aneurysm of the aorta, or foreign body inhalation. Compression atelectasis is due to any fluid or air in pleural cavity, that is pleural effusion or pneumothorax. Contraction atelectasis is due to focal or generalized fibrosis, such as in interstitial lung disease or any other chronic disease such as tuberculosis. The second one is anaphylaxis, a life-threatening condition that requires early intervention. It is a systemic type 1 or immediate hypersensitivity reaction. Just to recap, type 1 hypersensitivity can manifest either locally or systematically. Local manifestations such as asthma, food allergy, allergic rhinitis, eczema, and urticaria. Systemic is the one we call anaphylaxis. The principal inflammatory mediators are histamine, leukotrienes, and prostaglandin released in abundance by mast cells and eosinophils. This will cause widespread vasodilation and increase vascular permeability, so patients are predisposed to vascular shock and widespread edema. Laryngeal edema in particular are responsible to sudden dyspnea in anaphylaxis. It may also due to compensatory mechanism to vascular shock. Trigger for anaphylaxis varies among patients. The common ones are food allergy, drugs, and insect bites. Next is acute pulmonary edema. Pulmonary edema is the leakage of excessive interstitial fluid which accumulates in alveolar space. Like any edema, the underlying pathophysiology can be due to hemodynamic disturbances or increased capillary permeability. Disturbance in hemodynamics can be further classified into changes in either hydrostatic pressure or oncotic pressure. In left-sided cardiac failure, for example, there will be increase in pulmonary venous pressure, which will cause the fluid to exit the capillary and into the interstitium. This will cause edema like in other cases of edema elsewhere. However, further fluid accumulation will cause fluid to leak out of the interstitium and into alveolar space instead in severe cases. This is important to understand because these two distinct stages will manifest differently in X-ray. Second component of hemodynamic disturbance is changes in oncotic pressure. This occurs when there is hypoalbuminemia such as in nephrotic syndrome or chronic liver disease. So in theory, fluid will be pulled into the interstitium. However, pulmonary capillary, unlike other tissue capillaries, are more permeable to proteins. That means any changes in albumin concentration in the blood vessel will cause some changes in the albumin concentration in the interstitial fluid as well. Due to this quote-unquote directly proportional relationship between the two, this will not cause significant changes in the oncotic gradient between the two spaces. So hypoalbuminemia, such as in nephrotic syndrome and chronic liver disease, will rarely cause pulmonary edema. Due to this reason, pulmonary edema due to hemodynamic disturbance is also commonly referred to as cardiogenic pulmonary edema. Increased capillary permeability can be due to direct or indirect lung injury. Direct injury, for example, are aspiration of gastric content, pulmonary contusion in trauma, and reperfusion injury. Indirect injury, for example, are acute respiratory distress syndrome, which is seen commonly in sepsis, complication of pancreatitis, and transfusion-related acute lung injury. All of these causes are also grouped as non-cardiogenic pulmonary edema. Alright, now let's look into bronchial asthma. There are four features that define the pathology in asthma. First is airway hyperresponsiveness. This is a feature of hypersensitivity type 1 as we have seen earlier, which will lead to bronchial inflammation due to the inflammatory mediators released and cause reversible airway limitation. If it is not controlled, in the long term, it will cause airway remodeling such as increased goblet cells, basal membrane thickening, and smooth muscle hyperplasia. There are a lot of triggers for acute exacerbation of asthma, such as the following. Another variant of asthma, a more severe type, is called status asthmaticus, or also known as acute severe asthma. In this case, airway limitation is not reversed with repeated courses of common inhalants such as beta agonist therapy. Next is chronic obstructive pulmonary disease, which encompasses both chronic bronchitis and emphysema. Chronic bronchitis are simply chronic inflammation of the bronchus. But unlike asthma, this is due to chronic exposure to irritants, almost 80 to 90% due to tobacco smoking. And the immune cells predominantly seen are neutrophils, lymphocytes, and macrophages. The bronchial epithelium also may exhibit squamous metaplasia and dysplasia, but not to a degree that it becomes cancerous. Other than immune cells infiltrates, the mucus gland lining the bronchial also become hyperplastic. That means more mucus secretion. With poor ciliary function, this can also lead to bronchial plugging with mucus and eventually emphysema. Emphysema involves the respiratory portion of the airway. Chronic inflammation leads to fibrosis or scarring, so there will be loss of lung elastic recall, which is an important process of exhalation, because unlike inspiration, exhalation is mainly a passive process. With poor exhalation, air will trap in the distant airway and over time will cause permanent enlargement. And there are two types, pan-acina and centri-acina damage. Centri-acina damage involves enlargement of the respiratory bronchioles. This is the most common type. Pan-acina involves not only respiratory bronchioles but up to the alveolar duct and alveolar sacs. This damage is seen in patients with familial antitrypsin deficiency. Patients with this type of emphysema are also prone to develop bullous emphysema, more commonly in the lower lobes, whereas patients with a centri-acina is less commonly associated. But if it develops, the bullae is commonly at the upper lobe. In more severe case, air trapping causes severe pressure disturbance across the alveolar blood barrier. Patient can have pulmonary hypertension and cor pulmonale or right-sided heart failure. Other than tobacco smoking and familial alpha antitrypsin deficiency, other risk factors include exposure to biomass fuel gas and occupational dust, cadmium, or silica. Last one is pneumonia, which basically any infection involving the lung parenchyma. There are a lot of classifications for pneumonia from pathological, etiological, clinical, and radiological point of view, so we will try to explore each of them individually. Classification based on etiology is perhaps the most important because it suggests the likelihood cause of infective organism, hence its according treatment. We have 7 types of pneumonia in total: community-acquired, hospital-acquired, healthcare-associated pneumonia, aspiration pneumonia, chronic pneumonia, necrotizing, and opportunistic or pneumonia in immunocompromised hosts. In this video, we are going to cover community-acquired, hospital-acquired, and aspiration pneumonia. Tuberculosis is essentially a type of chronic pneumonia along with other fungal infections such as blastomycosis. Necrotizing pneumonia is also known as suppurative pneumonia or lung abscess. We will look into tuberculosis and lung abscess in part 2 of this video. Opportunistic pneumonia, for example, are infection by Pneumocystis jirovecii. That is a bit introduction to pneumonia. Before we divide into the specific etiological organism, let's first look at the pathological classification. This too is important because it helps us to appreciate the disease later, clinically and radiographically. We have bronchopneumonia and lobar pneumonia. Bronchopneumonia means patchy consolidation of the lung lobules. Lobar means consolidation of an entire lung lobe instead of lung lobule. More specifically, the immune cells involved in bronchopneumonia usually surrounds the bronchi, bronchioles, and the adjacent alveolar, which will cause foci of lobular consolidation, often involving multilobar, especially the lower lobes bilaterally. Lobar pneumonia is associated with pathology involving the lung lobe and the lung pleura. Classically, the abnormalities seen can be described into 4 phases: congestion, red hepatization, gray hepatization, and resolution. Congestion is vascular engorgement, filling of alveola with exudative fluids, but few neutrophils. Red hepatization happens when more cells are involved, such as red cells, fibrin, and more neutrophils in the alveolar space. Gray hepatization is when red cells disintegrates, and resolution when the exudates is broken down and ingested by macrophage. Lobar pneumonia also usually extend to the lung pleura. This can cause pleurisy and organization, which is fibrous thickening, and may also cause permanent pleural adhesion. Both of these features are seen in pneumonia caused by any etiological organism, so it is non-specific. However, lobar pneumonia is more commonly associated with Streptococcus pneumoniae, which is also called pneumococcus. Alright, now let's look into etiological classification that we are going to cover in this video. That is community-acquired, hospital-acquired, and aspiration pneumonia. The causes for CAP can be divided into bacterial and viral. There are lots of organisms for each group alone, and it is good if we can remember some of the common ones because some radiographic findings later may be associated with certain organisms. Streptococcus is the most common cause of CAP. Haemophilus influenzae and Moraxella catarrhalis are usually associated with acute exacerbation of COPD. Staphylococcus aureus associated with bacterial endocarditis among intravenous drug user and superinfection of viral pneumonia. Klebsiella is associated with chronic alcoholics and patients with debilitating illness, whereas Pseudomonas with immunocompromised patients. For the second group, the risks are usually environmental. For example, Legionella pneumophilia is associated with artificial aquatic environments such as pools, Mycoplasma with close crowded communities such as schools, military camps, and prison, whereas both Chlamydia and Coxiella are associated with exposure to certain type of animals. The first group are also known as typical organisms of CAP, whereas the later are atypical organisms. The way that you can remember these atypical organisms are LMCQ for long multiple choice questions, or any other mnemonic that suits you. Pneumonia caused by atypical organisms are usually milder, thus it is also called walking pneumonia, in the sense that these pneumonia do not seriously affect the patient's day-to-day activity. Other than that, there are other factors that differentiate these two groups as well, clinically and in terms of investigation and treatment. Other than milder cause of pneumonia, these organisms are also associated with more extrapulmonary manifestation, clinically as we will see later. These organisms also cannot be cultured on standard media or seen on gram stains, and they are also resilient or resistant to beta-lactams antibiotics. In that sense, all viruses are also considered as etiological agents for atypical pneumonia because they fulfill all these features. Examples of viruses are the following. Some points to note regarding viral pneumonia. The etiological agents are also common URTI agents, so sore throat, runny nose may precede the symptoms of dyspnea. It runs a milder clinical course with extreme varied manifestation of symptoms. In terms of prognosis, viral pneumonia usually resolve spontaneously and do not cause any lasting sequelae post-infection. That being said, death from viral pneumonia are commonly caused by superimposing bacterial infection, such as seen in swine flu or influenza H1N1, avian flu or influenza H5N1, and the Spanish flu back in 1918. These perhaps are similar to the current coronavirus COVID-19, but nothing can be surely said because this is still new and studies are ongoing. Risk factors that predisposes to pneumonia are impaired mucociliary apparatus such as in COPD and bronchiectasis, accumulation of secretions such as edema, and phagocytic interference such as effect of smoking. Or you can simply remember them as the following mnemonic. Causes of HAP can be divided into gram-negative rods and gram-positive cocci. Klebsiella, E. coli, and Serratia are common Enterobacteriaceae group associated with HAP. The commonest isolated organism for HAP are Pseudomonas. Methicillin-resistant Staph aureus is also commonly isolated in this group because hospitalization are also associated with prolonged antibiotics use. So for this group, other antibiotic regime is needed to treat this pneumonia. The risk factors for HAP are as follows. The last one is aspiration pneumonia. Organisms isolated are associated with oral flora, both aerobes and anaerobes. Anaerobes in particular are associated with poorer prognosis because these organisms can cause necrotizing pneumonia or pulmonary abscess. Risk factors to develop aspiration pneumonia are impaired consciousness, such as patient in seizure or put under general anesthesia for surgery, poor oral hygiene, and impaired gag or swallowing reflexes, such as in patients with stroke, Parkinsonism, or multiple sclerosis. Alright, now before we begin with clinical features for each disease, first let's look at the general physical signs associated with dyspnea because we can generally apply these to all disease. When we say patient in respiratory distress, it is a general term that encompasses a lot of signs such as tachypnea or bradypnea, chest recessions, use of accessory breathing muscles, speaking difficulties, or central cyanosis. There are a lot more, such as pursed lip breathing, grunting, coarse mouth breathing, tracheal tugging and pulsus paradoxus, and abdominal paradox, but they are more associated with a specific disease, so we will look at them individually later with each diagnosis. The cutoff point for tachypnea or bradypnea may differ according to your sources. The ones I'm using, which is Nicholas J. Talley, states that less than 8 for bradypnea and more than 25 breaths per minute for tachypnea. Average adult breath per minute is about 20, so sometimes 20 is taken by some as the cutoff point for tachypnea. Chest recessions or chest indrawing, which is the same thing, can be seen suprasternum, supraclavicle, intercostal, substernum, or subcostal. Use of respiratory muscles, for example, are sternocleidomastoid, scalenes, and platysma. Difficulty in speaking may be limited to only words, phrases, or sentences. The most severe, of course, is when patient is unable to speak at all. Cyanosis in respiratory distress is central. Secondly, for close respiratory examination, there are a lot of interchangeable terms and description of signs on auscultation, such as wheezing, rhonchi, crackles, rales, crepitation, bronchial breathing, vesicular, and so on, which cause some confusion. This is not surprising because between textbooks there are variation as well. So the source I'm using is Clinical Examination by Nicholas Talley and Simon O'Connor. Let's lay their description out so that we are on the same page when we address those terms in this video. We described 3 things on chest auscultation: breath sound, added or adventitious sound, and vocal resonance. We will focus on the first 2 because that is where lots of confusion are. For breath sound, we describe them in terms of intensity or quality. In terms of intensity, it is either normal, reduced, or absent. And we compare this for both sides of the chest, so either equal changes or one-sided. This is quite clear. For the second component, we can have either vesicular or bronchial breath sound. It is called vesicular because it is referring to alveolar sacs, which are vesicular-like structure. Bronchial because it is referring to the bronchus. Vesicular is described as continuous breathing sound, which duration of inspiration are longer than expiration, and it is heard in the chest periphery. Whereas bronchial is the opposite. It is interrupted because there is a gap between inspiration and expiration. The duration of expiration is equal or longer than inspiration and is commonly heard centrally because that is where our bronchi are located. So it is considered abnormal if we hear this sound from the chest periphery. How can bronchial sound be heard at the periphery? That is when there are presence of solid-like structure. Since solid conducts sound better than air, the sound of bronchial breathing is transmitted via the solid-like structure. so there is loss of sound filtering and more sound conduction instead. That also means, in order for the sound to be heard, the bronchi must be patent as well, because if there is no air passing through the bronchi, there is no sound to be conducted. Bronchial breathing is most commonly heard when there is lobar consolidation, because the exudates and cell infiltrates that fills the alveolar spaces makes the affected lobe more solid rather than airy. Less common causes are pleural effusion and localized pulmonary fibrosis. When there is pleural effusion, the adjacent airway will be compressed due to the fluid, which is also called compression atelectasis. The compressed lung structure becomes closer to each other, so less airy, more solid as it approximates. Thus, it is important to note that bronchial breathing in pleural effusion is not heard over the area of effusion, but adjacent to the effusion, commonly just above the effusion if patient is sitting upright or in proper position. Localized fibrosis can cause contraction atelectasis, so that can cause bronchial breathing as well. Bronchial breathing is not heard in resorptive or obstructive atelectasis because the airway is not patent. Now that we have looked into the difference between vesicular and bronchial breathing, what if the breath sound is non-interrupted, but the duration of expiration is equal or longer than inspiration, which are seen in obstructive airway disease such as asthma and COPD? It is not stated here in the textbook. Some clinicians address this as vesicular breathing as well, simply because there is no gap between inspiration and expiration. But others identify this as a separate entity, which is prolonged vesicular breath sound. The latter is in accordance with a recent published paper by Saka et al. In Annals of Thoracic Medicine in 2015. It also further elaborates two types of bronchial breathing, either tubular or amphoric. Tubular is sound of air passing through a hollow tube, whereas amphoric is the sound of turbulent air in cavernous or cavitating spaces. To differentiate this, the first is high pitch and the later is low pitch. Alright, now for added or adventitious sound. We have wheeze, crackle, and pleural friction rot. Let's concentrate on the first two. Wheeze is produced when there is airway narrowing, similar to how we whistle. It is non-interrupted sound with musical quality and is heard louder on expiration because the airway is more narrowed during expiration. In terms of its musical quality, it can be described as low pitch or ronchi when a larger airway is involved, and high pitch sound if a smaller airway is involved. Crackles is the opposite. It is interrupted, non-musical sound heard on inspiration. Previously, crackles is also described as having high or low pitch. High pitch is also called crepitation, whereas low pitch for rails. However, there is no significant distinction between the two, so a unifying term, crackles, is used instead. More importantly is to describe its timing and quality. Timing of the sound differs based on which airway is involved. More proximal airway will sound earlier and more distant ones will sound later. So we have early inspiratory, late inspiratory, and pan-inspiratory. Early is the sound coming from bronchi, late is alveolar in origin, pan means throughout inspiration, so both or bronchoalveoli. The quality of crackles explains the underlying lung pathology. You will find that most textbooks make a distinction between fine and coarse crackles, but Talley and O'Connor and Saka et al. Includes medium crackles as well. The first two is due to abrupt opening of small airway, whereas coarse crackles is the gurgling sound of retained lung secretion. Fine is also described as velcro-like sound or the sound produced when rubbing our hair between our fingers. This is seen in interstitial lung disease due to the abrupt opening of partially collapsed small airway during inspiration due to some degree of contraction atelectasis following the previous expiration. Pulmonary edema is described as medium crackles due to abrupt opening of airway across peribronchial or interstitial edema. So, for clinicians who does not include medium as a separate entity, he or she may describe pulmonary edema as fine crackles. Some would describe pulmonary edema based on their clinical experience as coarse crackles. Based on what we have learned earlier, pulmonary edema occur in stages, so severe edema can lead to fluid collection into alveolar spaces as well. So this perhaps explains why some describe them as coarse crackles. Disease that characterize coarse crackles is bronchiectasis. We will try to explain other diseases along the way, but I hope that gives you some perspective or understanding, because disease is not time restricted, it is dynamic, it changes with time. It either improves or worsens for patient, and I think that is how we should look at the disease and assess them as well. If anything, you can always hold on to your reference, and it is okay to have differences of opinion. Now that we have laid out the basics, let's continue to where we left off. We'll start again with atelectasis. Although I have grouped atelectasis under causes of sudden dyspnea, it actually depends on the size of the parts of the lung affected, rapidity of collapse, and presence of underlying lung disease. Small size atelectasis may not produce dyspnea at all, but large atelectasis involving a whole lobe may cause sudden dyspnea. Pneumothorax, large foreign body inhalation, are examples of rapid atelectasis. If patient has any underlying lung disease, he or she may has less tolerance towards changes in oxygen availability, so dyspnea may develop earlier. Now we know that it varies, but keep in mind that it can also cause sudden dyspnea. Patient may show signs of respiratory distress if severe. From close respiratory examination, massive atelectasis may cause ipsilateral shift of trachea, reduced chest expansion on the affected side, dull percussion because no more air in the collapsed lung, and absent breath sound or reduced because the sound may be transmitted from a distant patent airway. Next is anaphylaxis. This disease is diagnosed clinically. It is also an emergency, so quick identification of its clinical features, especially clinical signs, is very important. The initial symptoms of anaphylaxis can be innocuous, such as tingling sensation, warmth feeling due to sudden peripheral vasodilation, or itchiness due to histamine. This is followed by sudden dyspnea due to laryngeal edema, pre-syncopal symptom due to hypotension, swelling and rashes with increased vascular permeability. Clinical signs can be divided into those related to anaphylactic or distributive shock and signs due to increased vascular permeability. Signs of distributive shock are warm peripheries, facial flushing, tachycardia, and weak pulse. Laryngeal edema from increased vascular permeability will cause respiratory distress. Sign that is more suggestive of laryngeal edema is stridor, since this is an upper airway obstruction. Other signs include facial edema and urticaria. Alright, the third one is pulmonary edema. Here, the dyspnea rapidly progresses. Other suggestive symptoms is expectoration of pinkish sputum. Like other respiratory disorder, generally signs of respiratory distress is seen. Close respiratory examination reveals crackles. Now, we have discussed this just now. The sound produced is due to abrupt opening of airway with peribronchial edema, and in the later and more severe stage, fluid will collect in alveolar space. So either fine or medium crackles in the first case, or coarse crackles in the later. It is heard late inspiratory because this is alveolar disease. For cardiogenic pulmonary edema, it is commonly located bilaterally at posterior basal because this is dependent edema. For additional signs specifically for cardiogenic edema, we have covered them in the previous video. Next is bronchial asthma. The classical symptoms of asthma are dyspnea, wheezing, chest tightness, and coughing. Dyspnea in asthma is reversible with intervention, meaning that patient will resume normal breathing tolerance as other people do after the exacerbation is treated. They usually occur nocturnally or in the early morning because at this hour the surrounding temperature drops. It may occur at other times as well, depending on the trigger we listed above, because it varies among patients. History of other allergies such as rhinitis and eczema are also suggestive. It usually occurs among children, but about 1/3 of them will still carry this with them into adulthood. Generally, if patient happens to cough during examination, we may hear muffled, ineffective, wheezy cough. Ineffective because patient requires more effort to expire air. This is a sign of obstructive pulmonary disease. We should also examine the nose for nasal polyps, which is also suggestive of asthma and its associated allergies such as rhinitis. Barrel chest is when there is increased anterior-posterior to lateral diameter ratio more than 0.9. Some take 0.8 as the cutoff point. It suggests severe exacerbation of asthma or emphysema in COPD due to air trapping. Pectus carinatum is the outbowing of sternum. This suggests chronic childhood asthma because the bone is softer at this age due to delayed ossification. This is also seen in rickets. Other similar signs are Harrison sulcus, which are linear depression of the lower ribs due to similar reason. Suggestive signs from respiratory examination are tracheal tugging in severe asthma. This is due to depression of already flattened diaphragm from hyperinflation during inspiration. It is also seen in severe exacerbation of COPD. Other causes of tracheal tugging are laryngomalacia and aortic aneurysm, but the underlying mechanism of which tugging occur are different. Chest expansion reduces bilaterally because both sides are affected. Resonant on percussion or less commonly hyperresonant due to air trapping in severe case. Prolonged vesicular breathing due to difficulty in expiration and respiratory wheeze. If this is a case of exacerbation due to infection, we may hear other sounds as well, such as crackles in pneumonia. Alright, now let's look at COPD. The symptoms are roughly similar to asthma, but in COPD the main ones are chronic cough with sputum production, compared to wheezing or chest tightness. Dyspnea in COPD, unlike asthma, is irreversible. The exacerbation of dyspnea can be reversed, however, patient will not return to normal baseline tolerance again. As long as the chronic irritants such as smoking is present, the patient breathing tolerance will deteriorate over time. So the episodes of exacerbation is rapid, but the baseline gradually worsen over time from months to years. It is important to distinguish between the two. Cough in COPD is usually productive, either mucoid or mucopurulent. Sputum production is also more in the early morning because the lung secretion collects overnight when patient is sleeping. In COPD especially, we may want to inquire about symptoms of hypercapnia, which is commonly associated with COPD. Those symptoms are early morning headache and daytime sleepiness. We may also want to screen for cor pulmonale, which essentially are right-sided heart failure due to chronic emphysema. Examples of symptoms are reduced effort tolerance, lower limb swelling, and abdominal distension. For clinical signs, patient cough, if heard, is chesty and ineffective, similar to exacerbation of asthma. Barrel chest is also seen, and tobacco staining suggests cigarette smoking. Close respiratory examination may show tracheal tugging, reduced chest expansion bilaterally, similar to asthma. Another specific sign for COPD is called Hoover sign. This is when our thumb approximates together during inspiration, but pushed outward during expiration, which is the opposite to normal. This happens with severe lung hyperinflation. The chest can no longer expand outwardly, so accessory muscle will pull the rib downwards during inspiration to increase the vertical dimension. Percussion is also similar, resonant or hyperresonant with emphysema, and prolonged vesicular breathing and respiratory wheeze. In addition to wheeze, patient may also have early inspiratory coarse crackles due to lung secretion in larger airway. Patient with hypercapnia, if severe, can be drowsy or comatose. Bounding pulse, flapping tremor or asterixis, pulmonary erythema, facial flushing, and warm peripheries are also signs of hypercapnia. With cor pulmonale, patient is cyanotic with pedal edema, parasternal heave, and may also have jaundice, abdominal distension, and hepatomegaly due to hepatic congestion. This is also famously described as blue bloaters in comparison to milder earlier stage of COPD, which is described as pink puffers. The last one for this video is pneumonia. The clinical features of pneumonia varies according to the etiological agents from mild to severe. The 5 main symptoms of pneumonia are dyspnea, fever, chest pain, cough, and sputum production. In typical pneumonia, the onset of dyspnea is as rapid as 24 to 48 hours, but in atypical pneumonia, cause of dyspnea is milder and more gradual over a few days. Fever may be the earliest symptoms. Depending on the organism, it may be continuous, which is more commonly due to virus, or on and off fever, either intermittent or remittent, more commonly due to bacteria. Chest pain more commonly occur in lobar pneumonia. It is pleuritic, so they are sharp, non-radiating, aggravated with deep breathing, coughing, or sneezing. Cough can be productive or dry. If it is productive, the sputum can be mucopurulent, blood-tinged, or rusty-colored. The latter is also associated with streptococcus. These are the typical symptoms associated with pneumonia. Other than milder cause and more gradual dyspnea, atypical pneumonia is also associated with extrapulmonary symptoms. Myalgia, arthralgia, and malaise are systemic manifestations of immune reaction. These are commonly seen in infection by viruses, mycoplasma, and legionella. Sore throat, either laryngitis or tonsillitis, is common in viral infection because the pathogens are common agents of URTI. Diarrhea, vomiting, and abdominal pains, which may be due to gastroenteritis or hepatitis, are also seen in mycoplasma and legionella. Headache can partly be due to systemic immune response or meningoencephalitis due to similar organisms, and erythema multiforme in infection by mycoplasma. For signs, they generally look ill with respiratory distress with altered conscious state if severe. Close respiratory examination are slightly different for lobar and bronchopneumonia. Lobar pneumonia is characterized by reduced chest expansion, increased tactile and vocal fragmentus, dull on percussion, bronchial breath sound with late inspiratory crackles. Coarse crepitation is heard in severe alveolar exudative collection. However, fine crackles are heard during the 4th phase of pneumonia, that is in resolution stage. According to Sakar et al., the lung parenchyma gradually becomes drier and stiffer due to reduction in edema and healing process. So the pressure during inspiration opens the airway, causing fine crackles. For bronchopneumonia, the features are essentially similar but incomplete due to patchy consolidation. So percussion, tactile, and vocal fragmentus may be normal. The only presenting clinical signs may only be bronchial breathing and late inspiratory crackles. Alright, that is all for this video. In the next video, we are going to look at other diseases with gradual onset of dyspnea, such as tuberculosis, lung abscess, lung carcinoma, and interstitial lung disease. Then after that, we'll look into the approach to X-ray as a whole and perhaps other necessary investigation. If you find this helpful, share them with your colleagues, subscribe for future videos. Thank you for watching, bye bye.